Hi, let's see an NCLEX RN video based on fluid and electrolyte management, hypovolemia and hypervolemia. First question, in an elderly, which of the following impacts food and fluid intake? The options are increased sensitivity to smell, increased sensitivity to texture of food, decreased manual dexterity, decreased olfactory function. Hope this answer is easy for you because as we age, the sensitivity to smell and the sensitivity to texture of food decreases. It is not increasing. And the manual dexterity, though it is decreasing, dexterity means the ability to move our fingers and hands and all. So even though it is decreasing, it is not related to food and fluid intake. But the last one, decreased olfactory function, that is the answer because with aging there is decrease in taste, smell and thirst. Also, the olfactory fibers are decreasing and the receptors of olfactory fibers also decreasing. So, these fibers and receptors result in decrease in the ability to discriminate any smell. So this happens with the elderly. Along with the smell, their taste is also affected. There will be loss of teeth for the elderly. They will be having ill-fitting dentures. All these things will affect the food intake. They will be having decreased gastrointestinal motility. They will be on number of medications like diuretics also, which will affect the fluid and electrolyte balance. As they get age, their income gets reduced, there will be loneliness, depression, dementia, Alzheimer's. So many cognitive changes also will happen. Everything will contribute to decreased food intake by the elderly. So the answer for this question is decreased olfactory function. Now we need to know some normal values to understand fluid and electrolyte balance. First thing are certain indicators and their normal value. Already we have seen in the last video regarding osmolality. Osmolality is the amount of solutes present in the fluid. So serum osmolality is 275 to 295 milliosmoles per kg, near to 300. Urine osmolality is 500 to 1200 milliosmoles per kg. If you see the ratio between urine and blood osmolality, it is 3:1. Urine specific gravity, another indicator for fluid and electrolyte balance, is 1.005 to 1.030. Blood urea nitrogen normal value is 8 to 21 milligram per deciliter. Serum creatinine 0.5 to 1.2 milligram per deciliter. If you see the ratio between BUN to creatinine, it is 10:1 to 20:1. HB and hematocrit also helps to evaluate the fluid volume status. Hemoglobin and hematocrit will decrease, especially in fluid volume deficit. So you need to know the normal values. In males, HB is 14 to 17.3 grams per deciliter, and in females, HB is 11.7 to 15.5 grams per deciliter. The hematocrit in males are 42% to 52%, and in females 36% to 48%. We also need to know about normal values of some electrolytes. Serum sodium 135 to 145 milliequivalents per liter. Serum potassium 3.5 to 5 milliequivalents per liter. Serum chloride 97 to 107 milliequivalents per liter. Serum magnesium 1.6 to 2.2 milligrams per deciliter. Total serum calcium 8.2 to 10.2 milligram per deciliter. Ionized calcium 4.6 to 5.3 milligram per deciliter. Serum phosphorus 2.5 to 4.5 milligram per deciliter. When any problem with any of these indicators and electrolyte, the patient is going to be in risk. So you need to know about these normal values at least. Comparison of fluid volume deficit and fluid volume excess. What are the changes seen in the body when there is fluid volume excess and deficit? So the parameters a nurse need to assess is weight, heart rate, blood pressure, respirations, skin turgor, edema, jugular vein, urine output and urine specific gravity. At least these things the nurse should be assessing. The weight in case of fluid volume deficit is decreased, while in excess, the weight increases. Heart rate is increased in both cases. Blood pressure gets decreased with deficit and increased with excess. The respirations are clear when deficit is there, but when fluid volume excess is there, it will result in crackles and wheezing. Skin turgor is decreased in deficit, it is increased in excess. There is no edema in fluid volume deficit, but there will be dependent edema in fluid volume excess. The jugular veins are flat in fluid volume deficit, but there is a chance for distension in fluid volume excess. Urine output is decreased in deficit, it is normal or low in excess. The urine specific gravity is increased in fluid volume deficit and it is decreased in fluid volume excess. One point I would like to add is when fluid volume deficit happens are in conditions like vomiting, diarrhea, nasogastric suctioning, excessive perspiration, hemorrhage, diabetes insipidus, diabetic ketoacidosis and adrenal insufficiencies. And also it will happen if the patient is having nausea or anorexia or some problems in that makes them difficult to swallow, inability to communicate about the thirst. When we are treating this fluid volume excess in an aggressive way with the use of diuretics, all can result in fluid volume deficit. So when we are checking the lab values which we previously told, you can see that if the fluid volume deficit is there, there is elevation of serum osmolality. Because the fluid is less, the solutes are more. Urine specific gravity also same happens because in the urine the water content is less, solute contents are more. Urine osmolality also will be increased. The hemoglobin and hematocrit will be decreased because the amount of fluid or the liquid part is less. If we see about serum sodium, level of serum sodium is elevated with the loss of water. But potassium, what happens is that when there is diarrhea and all, there is passage of fluid and potassium also. So hypokalemia happens in fluid volume deficit. That is an important point you need to keep in mind. Then two words which I need to emphasize is oliguria and anuria. Oliguria means low urine output and anuria means lack of urine output. Now, when hypovolemia is there or when there is fluid volume disturbance, at that time the nursing management is first, as when we are seeing the fluid volume deficit, the nurse need to assess the health history, do a physical examination and see the previous findings are there or not, like weight, their skin turgor, all the things you need to see. Then you have to check for the diagnostic values, lab results you have to see, and we must measure the intake and output of the patient. When the patient is going for fluid volume deficit, there is chances of hypotension. The BP reduces, and here it is known as orthostatic hypotension, that is a decrease in BP within 3 minutes of standing compared to when sitting or in supine position. Immediately the BP is getting very much decreased. So when fluid volume deficit is there or when there is fluid volume excess, certain fluids we need to administer to the patient. Something known as crystalloids and colloids. The first one is crystalloids. Crystalloids are the liquids or the fluids which contain small molecules, and colloids contain large molecules. That is the main difference. So if we are seeing crystalloids, they are three types. One is hypotonic solutions, isotonic solution and hypertonic solution. Hypotonic solutions means compared to our serum, the amount of solute is less. So fluid will shift out of the vessels into the cells. Hypotonic solutions are given when there is fluid volume excess in the blood vessels. If you are finding fluid volume excess, at that time we will be going for hypotonic solution. 0.25% sodium chloride, 0.45% NaCl, 5% D5W, that is dextrose in water. Then the second one is the isotonic solution. It will not cause any fluid shift. 0.9% sodium chloride and ringer lactate. The third one is hypertonic solution. They will shift fluid back into the circulation. D5 0.45% NaCl and D5 0.9% NaCl. HS is hypertonic saline 3% or 5%. So these are the main IV fluid crystalloids we will be administering when there is fluid volume imbalance. Then if we see the colloids contains large molecules. So they are albumin, dextran, HES is hetastarch, then mannitol. These four things are the colloids. Albumin keeps fluid in the vessels. They are given as albumin 5% or albumin 25%. Dextran is a polysaccharide that shifts fluid into the vessels. 40K dextran or 70K dextran. Then hetastarch, it also shifts fluid into the vessels. Hetastarch 6% or hetastarch 10%. Then mannitol result in oliguric diuresis. Mannitol 5% and mannitol 25% are available. Whenever a patient is going for hypovolemia, at that time first you need to start with IV isotonic solutions. That is, we have to start with 0.9% sodium chloride or ringer lactate. Then once hypotension is okay or corrected, later only we have to think about correcting the electrolyte disturbance. So we will be giving hypertonic solutions at that time, that is D5 and 0.45% sodium chloride, D5 0.9% sodium chloride. It's a maintenance fluid. Here one question is, the nurse assesses for which clinical manifestation in the patient with hypervolemia. Here the patient is not having hypovolemia, the patient is having hypervolemia or fluid volume excess. So you need to think about the conditions when fluid volume retention or excess happens. It may be because of cirrhosis, heart failure, or maybe because of stress condition which causes release of antidiuretic hormone and aldosterone. So many because of other reasons like ingestion of so much of salt. Then if more sodium containing fluids are given, so every time this hypervolemia risk is there. The same lab investigations we will be seeing and we will be finding out whether the patient is in hypervolemia or not. And the clinical manifestations mainly seen in the patients with hypervolemia are weight gain, ascites, edema, increased urinary output and some cardiac manifestations that includes hypertension, tachycardia, elevated central venous pressure, then the development of S3 heart sound and jugular vein distension. So let's see the options given here. Bradycardia, it is wrong because tachycardia happens in hypervolemia. S3 heart sound, yes, S3 heart sound happens with hypervolemia. S3 is present because of the large amount of the blood volume that is entering the ventricles during diastole. So that is the answer. Then postural hypotension, that doesn't happen with hypervolemia, it happens with hypovolemia. Then decreased skin turgor, that also happens with hypovolemia. I hope you understood this video. Please do subscribe for more videos on NCLEX RN. Thank you so much learning with me.